Alright, so let's talk about diaphragm today. Now, this is the basic structure of the diaphragm that you can see. We have some hiatuses here, and so let's start from the first hiatus. Let's start from the basic structures rather. Okay, so here you can see these muscular fibers of the diaphragm, right? And these muscular fibers are merging into a common tendon. So when the muscular fibers from all sides fuse or merge, they merge into a common tendon or the central tendon of the diaphragm, right? And on the superior side, you have the foramen of Morgagni or the Larry's space. The foramen of Morgagni or the Larry's space, from where the superior epigastric artery and the superior epigastric nerve, or I'm sorry, the superior epigastric artery and the superior epigastric veins pass, basically the vessels, right? And then you have a few ligaments here. This is the medial arcuate ligament, and lateral to that will be the lateral arcuate ligament. Then you have the two crusts of the diaphragm. Here's the right crust and here's the left crust. And on the right side too, you have the medial arcuate ligament and the lateral arcuate ligament, right? And here's the sympathetic chain. Now let's talk about some major openings of the diaphragm. First, you have the vena cava opening at the T8 level. At the 8th thoracic vertebrae level, you have the vena cava opening, and it's present in the central tendon. As I've numbered this one, so the vena cava opening is present in the central tendon, and what structures pass through it? It's the inferior vena cava and the right phrenic nerve. Remember, the inferior vena cava is not affected by the contraction of the central tendon. I'm not saying the muscle of the diaphragm, but rather the central tendon. It's not affected. And so here's the right phrenic nerve, as you can see, and here's the inferior vena cava. And so they both pass through the vena cava opening at the T8 level. Next, we have the esophageal opening at the T10 level. So it's surrounded by the right crus of the diaphragm. Basically, it's present at the point at which the right crus of the diaphragm splits. Okay, so now as it's present in the musculature, when the diaphragm contracts, it will result in the closure of the esophageal opening, and this action is known as Pincock action. Okay, Pinchcock action basically. It's known as the Pinchcock action that if the diaphragm contracts, the esophageal opening will close. What other structures pass through it? It's the right and left vagus nerve and the esophageal branches of the left gastric artery. Okay, and the last opening, we have the aortic opening at the T12 level. It's present between the crus of the diaphragm. What structures pass through it? It's the aorta, obviously, the azygous vein, maybe sometimes the hemiazygous vein too, and the thoracic duct. Okay, here you can see the aortic opening. Here is the opening for the esophagus, and here you have the vena cava opening. And here you can see the two crusts, the right crus of the diaphragm and the left crus of the diaphragm. They fuse to form the median arcuate ligament. Okay, here is the median arcuate ligament formed by the fusion of the right crus and the left crus medially, right? And in the right crus you have the right splanchnic nerve, in the left crus you have the left splanchnic nerve and the hemiazygous vein. Now remember that the right crus of the diaphragm, remember this point, it is supplied by both right and left phrenic nerves. In this diagram you can see here is the left phrenic nerve reaching the diaphragm, reaching the right crus basically, and here you have the right phrenic nerve reaching the right crus. So it's supplied by both right and left phrenic nerves, the right crus. All right, some other structures in this diagram you can see. Here is the right inferior phrenic artery, the direct branch of the abdominal aorta. Here you have the esophageal hiatus, this one basically where the right crus is folding. Okay, here you have the vena cava opening, and here is the aorta. Okay, this is the sympathetic trunk running downwards. So yeah, these were the major structures, and here you have the medial arcuate ligament, the median arcuate ligament, the lateral arcuate ligament, and this triangle here is known as the lumbocostal triangle. Here you can see the 12th rib also, the lateral arcuate ligament, the medial arcuate ligament. Please don't confuse the medial arcuate ligament with the median arcuate ligament. Median arcuate ligament, as the name suggests, will lie in the midline. Okay, so yeah, now let's talk about some parts, or the muscular parts I should say, of the diaphragm. So first we have the sternal part. It arises by two fleshy slips from the back of the xiphoid process. Here you have the xiphoid process, this one, and it arises from two muscular slips. Can you see these muscular slips here? This one, which I am highlighting. So the sternal part arises from these two muscular slips. This one. All right. Next, you have the costal part, which arises from inner surfaces of the cartilages and adjacent part of the lower six ribs. Here you have the cartilaginous part of ribs and the muscle fibers arising from it. Okay. And next you have the lumbar part. In the lumbar part, let's study about the medial arcuate ligament first. So what's that? It's basically a tendinous arch and covering the upper part of the psoas major muscle. This is the psoas major muscle here. And what's covering the upper part of it? It is the medial arcuate ligament. Now to talk of the attachments here, where it is attached on the medial side, it is attached on the body of L1. Yeah, the medial side is attached to the side of the body of L1 vertebrae, and laterally it's attached on the transverse process. You can well appreciate here, if this is the medial arcuate ligament, it's attached on the side of the body of L1 and on the lateral side on the transverse process. And what will arise from the transverse process? It will be the lateral arcuate ligament, and where it will attach on the 12th rib. Okay, so the lateral arcuate ligament, it's covering the upper part of the quadratus lumborum. Here you have the quadratus lumborum muscle, and what's covering the upper part of it? It's the lateral arcuate ligament. Attachments we've already studied, attached medially in front of the transverse process of L1 and laterally to the 12th rib. Okay. Now in the last we have the two crusts, the right crust and the left crust. The right crust is larger, longer and stronger than the left crust, and basically it pulls the liver downward during each inspiration. Why? To make space for the lungs to expand during inspiration. It arises from the upper three lumbar vertebra body, and as the left crust is shorter, it arises from the upper two lumbar vertebra body. Okay, and I've already told you about the medial arcuate ligament. It's formed by merging the medial margins of two crura. The right and the left crura fuse, the medial margin fuse to form a median arcuate ligament right here. This one. Okay. Now the two domes of the diaphragm, if we talk about, the right dome, as you can clearly appreciate in this picture, is higher than the level of the left dome. In full expiration, it reaches the level of the fourth intercostal space, but the left dome reaches till the level of fifth rib. Okay. Now again, let's revise the major openings, how they are formed, the shape of it, and the major structures passing through it. First, we have the vena cava opening at the T8, formed by the junction of right and median leaflets. The shape is quadrilateral. Remember the shape, it's very important. The shape of the vena cava opening is quadrilateral. And what structures pass through it? Obviously the IVC, along with the right phrenic nerve and lymphatics of liver. And if the musculature now contracts, the vena cava will dilate. Why? To aid venous return to the heart. Right. Remember, it's not affected by the contraction of the central tendon. But if the musculature of the diaphragm contracts, then the vena cava will dilate. Second, you have the esophageal opening present at the level of T10, formed by the splitting of the right crust. Okay, if this is the esophagus, the right crust was covering it like this, right? The opening is elliptical opening. And what structures pass through it? Obviously the esophagus and the esophageal branches, the artery from the left gastric artery, gastric nerves will be passing. Okay, and if the diaphragm contracts, the esophagus will constrict. And the last, you have the aortic opening at the T12 level behind the median arcuate ligament. If this was your median arcuate ligament, so posterior to that or behind that will be the aortic opening. It's rounded and the structures passing are aorta, azygous vein and the thoracic duct. And remember, if the diaphragm contracts, it has no change on aorta, no change in the aortal opening. Okay, and here you can diagrammatically see a schematic diagram of major openings. This is the IVC, the esophagus, aorta, IVC at the level of T8, esophagus at the level of T10, and aorta at the level of T12. Okay, so yeah, now if we talk about some relations here, they are very easy. Of course, superiorly, but you have the lungs and the pleura and the pericardium. And what will you have inferiorly? The peritoneum, that's very obvious, and all the major soft organs like the liver, the fundus of the stomach that is covered by diaphragm anteriorly. So it's okay. And the spleen, the kidney, and the suprarenals. Right? And again, we have one diagram here in which you can appreciate the Larry's space, okay, the foramen of Morgagni, from which the superior epigastric vessels pass. Right here you have, and if we talk about the vena cava opening, here's the inferior vena cava. Along with that lies the right phrenic nerve. In the esophageal opening, you have the esophagus, the right and the left vagus nerve. This is the left vagus, and this is the right vagus nerve here, along with the esophageal branch of the left gastric artery and the accompanying veins. Here you can see the artery and the vein. And then behind the median arcuate ligament, you have the aorta, the abdominal aorta running. And here you have the two crusts, the right crust, the left crust. Here you have the sympathetic chains running. And remember these subcostal nerves and vessels, the van relation, subcostal vein, subcostal artery, and the subcostal nerve below the 12th rib. And in the right crust, you have the greatest splanchnic nerve and the lessest splanchnic nerve. Okay, and here's the sympathetic trunk. We already talked about this. And it's labeled subcostal nerves and vessels, which we've already talked about enough. Right. Now another diagram here in which you can clearly appreciate the splitting of right crust, okay, to form the esophageal opening at the level of T10, right? And the two muscles, psoas major muscle covered on the upper side by median arcuate, and the quadratus lumborum muscle covered on the upper side by lateral arcuate ligament. Now if we talk about the nerve supply of the diaphragm, it's supplied by phrenic nerves from the ventral rami, the C3, C4, C3, C5 and their motor nerves. The C4 is the chief motor nerve to diaphragm, and the sensory nerves, if we talk about, the phrenic nerve are sensory to the central part, and to the peripheral part, the lower 6 thoracic nerves are sensory. Now the position of the diaphragm in the thorax. It basically depends on three factors. Let's take these factors one by one. The elastic recoil of the lung tissue tends to pull the diaphragm upwards. That's very obvious. If the lung tissue tends to recoil, when the lung tissue recoils in case of expiration, so of course in case of expiration the diaphragm is pulled upwards, right? And when you lay down in the supine position, basically what will happen? The abdominal viscera will push upon the diaphragm and exert a pressure. So the diaphragm will be pushed upwards, and while you're standing, the viscera tends to pull the diaphragm downwards. So on standing and sitting, the viscera tend to pull the diaphragm downwards. That's very obvious. Now while standing, the muscles in the abdominal wall contract, which increases the intra-abdominal pressure, and this pressure tends to pull the diaphragm upwards. But while you're sitting or laying down, the muscles are relaxed and the diaphragm is pulled downwards. Now if we combine all three factors, the crux of the discussion is that the level of diaphragm is highest in the supine position when you are laying down, lowest while sitting, and intermediate while standing. Okay, so the higher is the position of the diaphragm, the greater respiratory excursion is there. All right. So remember, the level of the diaphragm is highest in the supine position, intermediate while standing, and lowest while sitting. Now some applied anatomy. The hiccups, they can be due to two types of irritation, the central irritation and the peripheral irritation. Peripheral is due to the local irritation of the phrenic nerves or the diaphragm, and the central is due to the irritation of hiccup center in the diaphragm. Uremia is a very potent irritant of the hiccup center in the diaphragm, therefore, an important cause of hiccups. Now, the reason for the referred pain in the tip of the shoulder, sometimes due to pain in the diaphragm, is because of the common nerve supply. The phrenic and the supraclavicular nerves have the same root values C3, C4, and C5. Alright. Now, the unilateral paralysis of diaphragm. If there is a lesion due to any phrenic nerve, it will result into the paralysis of the muscular fibers on the and the paralyzed site will move to the normal side. Okay. Then we have the eventration of diaphragm, eventration of diaphragm, which is a condition in which it is pushed upwards due to a congenital defect in the musculature of this left half. Remember, let's have a look at this diaphragm showing the eventration of the diaphragm. Now you can see the left dome is pushed upwards. Okay, so there is very less space for the left lung. It can also cause respiratory distress in the newborns, right? You can follow up. So the left dome is pushed upwards. Attenuated, eventuated leaf of diaphragm, basically on the left side, right? So you can appreciate the diagram. The right leaf is normal, but the left leaf is pushed upwards. Now we come on to the hernias of the diaphragm. They can be of two types, either congenital or acquired. Let's first talk about the congenital hernias. First, you have the retrosternal hernia, in which the contents can protrude out through the foramen of Morgagni or the space of Larry, and it's more common on the right side. Remember the space we talked about, the Morgagni foramen or the Larry's space, from which what was passing? The superior epigastric vessels, the artery and the nerve, right? Now, the second is the posterior lateral hernia. It's the commonest type of congenital hernia, and it's a developmental anomaly in which there is a foramen. Can you see this foramen? If there is a protrusion of any structure from this foramen, it's called the posterolateral hernia, and it's more common on the right side. The retrosternal was more common on the right side, and this is more common on the left side. Okay, and such a hernia may cause death of infant within a few hours of the birth due to acute respiratory distress caused by abdominal viscera filling the left chest. The abdominal viscera will protrude through this foramen, and where it will go? Into the pleural space, right? So the lung doesn't has enough space to expand, causing respiratory distress. Now the posterior hernia, it's due to the failure of development of posterior part, and the central hernia, it's rare and remember on the left side. Not much to discuss in these parts. Let's move straight to the acquired hernia. Now acquired can be due to trauma, that is due to bullet injuries, and it can be a hiatal hernia. Now hiatal further can be congenital or acquired. Let's first talk about the rolling type, the congenital hiatal hernia. What happens in this type is that stomach can roll upwards until it lies upside down. Okay, it's the rolling type of hernia. What happens in this, that the normal relationship of the cardioesophageal junction remains undisturbed. If you see this diagram here, this one, the rolling hiatus hernia, what has happened? A part of the stomach has rolled up, but where is the cardioesophageal junction? Or rather, I should say, yeah, the cardioesophageal junction. It's at this level and it's undisturbed. Okay, so just a part has rolled up, but the cardioesophageal junction is undisturbed between the esophagus and the cardiac part of the stomach. It remains undisturbed in case of rolling type. But in the next type, that is the sliding type of the hernia or Acquired hiatal hernia, which is the commonest, is due to the weakness of the phrenico-esophageal membrane joining the diaphragm and the esophagus. If that membrane is weak, and it can be due to obesity and operation in this area, what will happen? The part of the stomach or the esophagus will slide up. Okay, it will slide upwards. Now, you tell me, will the cardioesophageal junction remain undisturbed? No, it will also be lying somewhat here because the whole of the contents have slide up, right? So the cardioesophageal junction is disturbed in this case, causing reflux of gastric contents into the esophagus. Causing reflux of gastric contents into the esophagus as the cardioesophageal junction is disturbed in this case. You can clearly see the difference between the sliding type and the rolling type. Okay, so I guess we are done with diaphragm here. Let me see if anything is left. Yeah, these relations are important, and remember the shape of the vena cava opening, quadrilateral. The esophageal opening is elliptical in shape and rounded in case of the aortic opening. The superior and inferior relations, keep in mind, though they are very easy to remember. So yeah, we're done with diaphragm here. Thank you very much.